So last time we had a class on water-soluble vitamins. Now we will have fat-soluble vitamins. What do you understand by vitamins? So vitamins may be regarded as organic compound required in the diet in small amount to perform specific biological functions for normal maintenance of optimal growth and health of the organism. Organism includes all, human being also. Now, in last class, we have discussed about classification. They are fat-soluble vitamins, water-soluble vitamins. Fat-soluble vitamins are A, D, E, K, and water-soluble vitamins, two types, non-B-complex and B-complex. Non-B-complex is vitamin C, and B-complex is again divided into energy releasing and hemopoietic. Energy releasing vitamin B1 is thiamine, riboflavin, niacin, then pyridoxine, biotin, and pantothenic acid. Hematopoietic, folic acid, and vitamin B12. Hematopoietic is because of it is very much essential for the formation of the hemoglobin. Among these, sulfur containing vitamin is B1, B5, B7. Please note, sulfur containing vitamin B1, B5, B7. Water soluble vitamins exert function through respective coenzymes, and only fat soluble vitamin that has identified to be functional as coenzyme is vitamin K. Okay? Fat soluble vitamins they do not have coenzyme except vitamin K. This is the only vitamin K and fat soluble vitamin having coenzyme activity. So fat soluble vitamin in general, they are 4 in numbers A, D, E, K. All fat soluble vitamins are isopenoid compound. They have a isopenoid. Their isopenoid compound has 1 or more 5 carbon unit. This is the isoprene unit. Okay. So they will have 1 or more this unit, isoprene unit. They are soluble in lipid or oil and also soluble in fat solvent like alcohol, acetone, etc. Their availability in diet, absorption, then transport associated with fat. They need fat for getting digested and absorbed. Sometimes, when patient have constipation, that is hard stool, to make his stools soft, sometimes doctors prescribe paraffin containing suspension, so that the stool of the patient become. So they sometimes prescribe paraffin. Paraffin is not absorbed; it is expelled out with the stool, and this is a fat. And with that, when we give paraffin for a long time, with the paraffin, these fat soluble vitamins also get expelled from the intestine. So there is lack of fat soluble vitamins when paraffin is given for prolonged period. So they are soluble in their ability in diet, absorption and transport is associated with fat, can be stored in the liver and adipose tissue, not readily excreted in urine. So, as it is not excreted readily, so there is possibility of toxicity of fat soluble vitamins when given in large quantity for a long time. Vitamins, the term vitamins represents the chemically similar substance that processes qualitatively similar vitamin activity. Like in the last class, we told pyridoxine, pyridoxal, and pyridoxamine. They are the vitamins of B6. Vitamins of vitamin A are retinol, retinal, retinoic acid. Like that, they will have similar structure and qualitatively similar activity. Provitamins are the precursor or inactive form of vitamins. Example given beta carotene for A. Then cholecalciferol for vitamin D. They need some modification to release the active form of the vitamin. Vitamin A, it has three vitamins: retinol, retinal, and retinoic acid. The word retinoid is used collectively to include natural and synthetic form of vitamin A. Okay, all the vitamin A are not naturally available. Sometimes we give synthetic form of vitamin A in the universal immunization program to prevent the vitamin A deficiency. We give babies dose of vitamins every 6 months, 5 doses. Okay, those are synthetic vitamins. So all these naturally and occurring and synthetic vitamins, they are together called retinoids. Now, vitamin A has a isoprenoid ring, beta-ion ring with 2 isoprenoid unit and 4 double bonds. In the isoprenoid unit, when alcohol is there, it is called retinol. When aldehyde group is there, it is called retinal. And when carboxyl group is there, then it is called retinoic acid. This retinol and retinal, they are interconvertible. But retinoic acid, it cannot be converted to retinal or retinoids. Retinol. Retinol is present in animal tissue as retinyl ester with long chain fatty acid. It has a vegetable source also and animal source also. In animal source, we get as retinyl esters, and in vegetable source, we get as beta carotene. Beta carotene is available in plant food. It is cleaved in the intestine to give 2 moles of retinal. So 1 unit of beta carotene can give 2 moles of retinal. In human, conversion is inefficient, hence beta carotene has only 1/6 activity of the retinol. So whatever the non-vegetarian source is there, the full amount of benefit from beta carotene we don't get, only 1/6 we get. Retinol, it is mainly responsible in the reproductive system. Retinal in normal vision. Retinoic acid, it is responsible for growth and cell differentiation, and carotene functions as antioxidant. Active form is retinol, and it is available in animal origin of vitamin A. And provitamin beta carotene, it is available in plant tissue, and it needs modification to release as vitamin A. Here, the 3 vitamins are mentioned. This is the beta iron ring, this is the iron ring, and this is the isoprene chain, side chain. So, this is the structure of retinol. On oxidation of the retinol, we can get retinal. This is the alcohol group, and on oxidation, it gives aldehyde group, and the retinal is obtained. It is retinaldehyde. Then further oxidation of the retinal, we can get retinoic acid. These two, retinol and retinal, are interconvertible. Retinol can be reduced to retinol, or retinol can be oxidized to retinol. But here, once the retinol is oxidized to retinoic acid, it is not convertible, and it can this retinol is, cannot be formed from retinoic acid. This is the beta carotene. It has two beta ion rings and 4 this isoprene unit. So it is cleaved here. When it is cleaved here by the hydrolysis, then it gives this side one retinol and this side another retinal. Now, dietary source, animal source, it is present in milk, butter, cream, cheese. Can you see? Cheese, then egg yolk, fish, liver oil, then cod liver oil, shark liver oil. Active form of retinol or retinoid ester is present in animal source. Dietary source, vegetable source, it is carrot, papaya, mango, pumpkin, green leafy vegetables. Yellow or orange color food is full of beta carotene. Daily requirement, the retinol activity equivalent is equal to 1 retinol activity is equal to 1 microgram of retinol or 2 microgram of beta carotene. So it is daily requirement is expressed as retinol activity equivalent. So in men 750 to 1000 microgram per day. In women 750 microgram per day. Pregnancy 1000 microgram per day, and children 400 to 600 microgram per day. Digestion, absorption and transport. Now we get from the vegetable, we get beta carotene in plant source. So beta carotene is absorbed in the intestinal epithelium. Then it is hydrolyzed to give 2 units of retinol. Then it is oxidized to retinol. Again, from the animal source, it is present as retinal ester. Here in the lumen, it is hydrolyzed to release free fatty acid and release free fatty acid and retinol. Retinol gets absorbed in the intestinal epithelium. Then both from animal source and this plant source, it is again re-esterified with free fatty acid and gives retinal ester in the epithelium. For absorption, digestion and absorption, the bile cells are essential for fat-soluble vitamins. Bile cells, they cause emulsification of the vitamin A, that means fat. So along with that, the vitamin A also get emulsified with the fat and they become available for the enzymatic digestion. And their absorption requires micelle formation. Micelle formation is caused by bile salts. So they are absorbed in the epithelium and accordingly this reaction takes place. After that, this retinal ester, it is transported through chylomicron through the thoracic duct to the blood, and from there it is transported to the liver. In the liver, some amount of retinal, this vitamin A is stored as retinal palmitate, and others they form all trans retinol, and retinol is released in the blood. It binds with the retinol binding protein. A part of the vitamin A is stored in the liver as retinol palmitate, and rest they are released in the blood and they bind with retinol binding protein and prealbumin, also called thyretin. This is carried to the target tissue. Now, these target tissues are retina, skin, gonad, and other tissues, and accordingly, depending on the target tissue, there is this vitamin A functions. Now, this retinol binding protein from blood, it is shifted to the cell of the target organ. Here, retinol binding protein coming to the contact with the target tissue, it releases retinol, and the retinol binding protein gets separated and goes back to the liver, the blood. This retinol, it inside the cell, it binds with cellular retinol binding protein. Then this retinol, it forms retinoic acid. That retinoic acid, it binds with the cellular retinoic acid binding protein. This complex, it gets inside the nucleus and it binds to the nuclear receptor. Retinoic acid receptor or retinol X receptor. So it can bind here, and accordingly it influences the expression of the gene. So once gene is expressed, mRNA is synthesized. That mRNA is nothing but the template of protein synthesis. So mRNA, it comes out from the nucleus to the cytoplasm, and that specific protein is synthesized. This protein is responsible for differentiation of the cell. So here are some biochemical roles of vitamin. It plays an important role in vision, then reproduction, growth and differentiation, immunity, epithelialization, then transferrin synthesis, gluconeogenesis, cholesterol synthesis. It has a role in this. Then antioxidant function. Coming in about the role of vitamin in vision. So this is the picture of retina. Here the rod and cone cells are present in the retina. So the role of vitamin A in the vision, it is described by George Wald, and according to his name, it is called Wald's visual cycle. The change that occurs in the rhodopsin during photoexcitation is called Wald's visual cycle. So it's very important. You will get short note. This is the rod. Here discs are there, and here rhodopsins are there. Rhodopsin is nothing but the 11-cis retinal who is bound with opsin. Opsin is a protein. So rhodopsin is present in as visual pigment in the rod cell. Okay. Now on getting excited by the light, this 11-cis retinal is isomerized to form all trans retinol. All trans retinol. And the opsin is released. There is a conformational change in the opsin. That due to that conformational change, there is visual excitation and nerve transmission of the whatever we see in the light. That excitation, it passes through the nerve to the cortex, and it is analyzed there. So this all trans retinal, it is got separated from opsin, and there is visual excitation. Now this rhodopsin has to be resynthesized. So some amount of all trans retinal, it is isomerized by the retinal isomerase into 11-cis retinal, and it combines with the opsin and to form rhodopsin. That means majority of the all trans retinal, they are carried to the liver through blood. Here, alcohol dehydrogenase, with the help of enzyme alcohol dehydrogenase, the all trans retinal is converted into all trans retinol. So don't confuse. This is all trans retinal, and here when it is brought to the liver, it is all trans retinal converted to all trans retinol. Okay, from the aldehyde to alcohol retinol. Remember, A is first, O is later. So retinal is first. It is converted to retinol. Now in the liver, it is isomerized to 11-cis retinol. Again, 11-cis retinol is converted into 11-cis retinal by the same enzyme alcohol dehydrogenase in the liver, and via blood it goes to the retina and takes part in regeneration of the rhodopsin. So visual cascade. We have seen that there is visual excitation. How this visual excitation takes place? This is another pathway. So visual cascade for phototransduction. This is also important. And here what happens? The rhodopsin. Here is the rhodopsin. It is nothing but the Z protein coupled receptor. Rhodopsin. What happens when light excitation is there? The G protein bound to rhodopsin, which contains alpha and beta gamma subunit. Alpha, beta, gamma. Here, alpha, beta, gamma subunit. Here, it is bound to the with GDP in normal case, in resting state. So when there is excitation, GDP is replaced by GTP. As soon as it is bound to GTP, the alpha subunit and GTP, this pair, it gets separated, and it activates enzyme GMP phosphodiesterase. GMP phosphodiesterase. This GMP phosphodiesterase, it converts cyclic GMP to 5' GMP. Okay. Now this GDP and G protein together called transducin. So this transducin become activated as alpha beta gamma subunit bound with GTP. So this active transducin, it will activate this cyclic GMP phosphodiesterase. This phosphodiesterase will convert cyclic GMP to 5' GMP. So there is a depletion of cyclic GMP, and this depletion causes closure of the sodium channel. Now, as there is sodium channel closure, the sodium cannot enter inside, and there is hyperpolarization. That is the neuronal signal. Okay, hyperpolarization, and the nerve signal is generated. Now, how this transducin is activated? Here, the rhodopsin, it undergoes a series of modification. Luminorhodopsin, metarhodopsin 1, metarhodopsin 2. So, metarhodopsin 2 is the functional molecule that activates transducin. Here, the pathway is like that. Rhodopsin is converted into metarhodopsin, which is the active molecule that causes inactive transducin to transducin. Inactive when it is GTP bound, and it becomes active when GTP is bound to the transducin. And this active transducin, it activates inactive phosphodiesterase to active diesterase, and it causes cyclic GMP to, it converts cyclic GMP to 5' GMP. Cyclic GMP, it is responsible for opening of the sodium channel. So when there is depletion, the sodium channel is closed, and that causes hyperpolarization, and thus the neuronal impulse is generated. Now, one thing is that dark adaptation. So when we are in bright light, all the rhodopsin, they are exhausted because light hitting the retina, there is splitting of the rhodopsin into opsin and 11 all transretinal. So there is no rhodopsin remaining in the retina. So as soon as we enter in the dark room from a lighted area, bright area, for the timing we cannot see anything because the dim light which is coming to our eyes doesn't cause excitation of the nerves due to the temporary lack of rhodopsin. After a moment, say a few seconds or 1 minute, 2 minutes, the rhodopsin is regenerated and the visual cycle is re-established, and we can again see that in the dim light. So this is the time taken to get the rhodopsin back is called dark adaptation time. When the person suddenly shifts from bright light to the dark area, it takes some time to get vision. Time taken to get vision in dark is called dark adaptation. This is the time required to synthesize rhodopsin pigment. In vitamin deficiency, there is lack of 11-cis-retinal, so there is lack of rhodopsin. That's why vision in dim light is decreased. Vision in dim light is decreased, so there is night blindness or nyctalopia, night blindness. And in vitamin deficiency, the dark adaptation time is increased because there is synthesis of rhodopsin is very slow due to the lack of vitamin A or 11-cis-retinal. This is the its role in vision. Now, its role in growth and differentiation. So, as you told, the retinoic acid, it combines the cellular, the DNA in the DNA binding area. So, this is for retinoic acid receptor, and this is for other than retinoic acid. So, it is cis retinoic acid. Here, it can bind in this one. So, there is synthesis of RNA, mRNA, transcription. Then there is translation of specific protein, and there is that protein is responsible for the cell differentiation. This is important for earliest process of embryogenesis, differentiation of 3 germ layers, then organogenesis, then it is responsible for sulfation of mucopolysaccharides in bone and cartilage. Now, in reproductive system, retinol is very much required. It supports spermatogenesis, prevent fetal resorption, then control expression of certain gene during embryogenesis. Fetal resorption, it is not reabsorption, okay, it is resorption. Because after the organogenesis, sometimes due to some reason, unwanted reason, that fetus die in the mother's womb. So it is reabsorbed in the system of the mother. Not all, but when it is very small, then it is reabsorbed. That is called resorption. That resorption is help. It occurs with the help of this vitamin A. Antioxidant. The beta carotene is mainly responsible for the antioxidant property. It removes the peroxyl and free radicals from the tissue under anaerobic condition. Decrease risk of certain cancer. Example given lung cancer, because free radicals and carcinogenic agents are responsible for producing cancers in the body. So, beta carotene, it neutralizes these free radicals and it helps to bind and inactivate the carcinogenic agent. Then decrease incidence of heart disease, lung, skin cancer, etc. Heart disease because it prevents oxidation of LDL. LDL is responsible for atherosclerosis. So it prevents oxidation. Okay, because it itself gets oxidized. Saving the LDL from getting oxidized. The same way, it decreases the risk of cataract. Cataract means the lens of the eye, it gets opaque. That is called cataract. So, due to its antioxidant property, it prevents this cataract formation to some extent. Immune system, retinoic acid, it is responsible for improving the immune function of the body by differentiation of the T cell into regulatory T cell. Vitamin A deficiency decreases formulation of hematopoietic stem cell because it helps in this hemoglobin production also. Effects on skin and epithelium. It is responsible for maintenance of normal epithelium and skin. It 13-cis-retinal inhibits keratin synthesis. Deficiency lead to keratinization of epithelial tissue of the skin, respiratory mucosa, gastrointestinal tract, genitourinary tract. What happens? You have seen the skin of the soul. This is very thick, no? It is because of the in the soul the skin has keratinization. So that in the skin of the hands and legs also it is there. So keratinization, it controls hyperkeratinization, vitamin A. In absence of vitamin A, there is increased keratinization and there is formation of dots-like irregularities in the extensor surface of the hand and limbs. That is called phrenoderma, toad skin. Then, because of the poor epithelial differentiation, there is increased tendency of formation of stone in the urinary tract. Then glycoprotein synthesis, it has a role in synthesis of glycoprotein and thereby in mucus. In the glycoprotein synthesis, when it is held, this improve the mucus synthesis. Vitamin A deficiency causes dryness of the epithelial tissue. It is because of in its deficiency there is less glycoprotein synthesis. That's why. Then it also helps transferrin synthesis, retinoic acid and retinol. And transferrin is nothing but the iron it carries the iron, and this is responsible for producing anemia also, reduced hemoglobin synthesis. Glycogenesis, it has a role in glycogenesis through the formation of corticosteroids from adrenal cortex. Then cholesterol synthesis, in case of vitamin A deficiency, the mevalonate is an intermediate product of cholesterol synthesis, and that is diverted towards from coenzyme A in vitamin deficiency. So when you read cholesterol synthesis, you will find this mevalonate. So these are some functions of vitamin A. Causes of vitamin A deficiency: dietary intake when it is low, then low birth weight in preterm infants because of the deficient absorption of the vitamin A due to immature gut. Then secondary, like obstructive jaundice, celiac disease, pancreatitis, liver cirrhosis, and chronic nephrosis. In case of obstructive jaundice, the bile salts, it cannot come to the intestine because of the obstruction of the biliary tract. So it cannot come, so it cannot, emulsification is improper, micelle formation is not there, so there is this vitamin A absorption, digestion absorption is disturbed. That's why there is vitamin A deficiency in obstructive jaundice. Celiac disease, same thing, there is a problem in digestion. Pancreatitis, it has pancreatic hydrolysis, hydrolysis of the beta carotene occurs, so it doesn't occur in the intestine. That's why there is decrease in vitamin A. Same thing, liver cirrhosis, the bile salts are disturbed. Chronic nephrosis. In chronic nephrosis, retinal binding is excreted in the urine. It passes away. That's why there is the transport through the blood is disturbed. Manifestations: night blindness, the patient cannot see in the dim light. Then xerophthalmia means dryness of the eye. The conjunctiva, bulbar conjunctiva, and the palpebral conjunctiva, it becomes dry. Okay, so this is xerophthalmia. Bitter spot in the eye, in the outer aspect of the eye, both sides, you will find a whitish clump-like collection. Okay, it is not like that. You can easily remove. Okay, it is inside the epithelial layer. So you can find a whitish degenerated spot. This is called bitter spot. Keratomalacia. Here, when it is not treated, the cornea it becomes affected. There is infection in the cornea. It becomes opaque. So it is called keratomalacia. The cornea it becomes soft. The vitreous humor, the aqueous humor, it comes out through this cornea. Okay, that's why it is called keratomalacia, soft cornea. Now, xerophthalmia, according to WHO classification, they have classified into beginning preliminary state, night blindness in the children, then comes, if not treated, then conjunctival xerosis, then comes bitter spot. After that, if it is not treated, then corneal xerosis. This is conjunctival xerosis. the bulbar conjunctiva and palpable conjunctiva. Okay. Now, in case of X2, it is the corneal xerosis. The transparent part, it becomes dry. So once it is dry, there is secondary infection. Okay, and that will cause keratomalacia. And it is X3A, means 1/3 of the cornea will be involved. X3B, it is more than 1/3 of the cornea will be involved. Then XS, there will be corneal scar. There will be corneal scar. Then XF, there will be xerothalmic fundus. The eye gets so it gets soft and dissolved. Its epithelium gets burst, and from the eye everything comes out, vitreous humor and all these things. Then it gets dry. So it is xerothalmic fundus. Sometimes we find in the still now you can find this xerothalmic fundus. Eyes are shrunken and closed. Okay, they cannot see, the blind one. So here see, here there's through the cornea a small bubble-like thing has come up. Cornea has become soft, and the aqueous humor it is coming out. Okay. Then keratomalacia, the whole cornea has become opaque. This is the bitter spot, and this is the normal eye, and this is the eye with cataract. This is the crinoderma. These things, the small eruptions are there. There is follicular epithelium atrophy, keratinization, then in the crinoderma. Then urinary calculi will be formed due to the degeneration of the urinary epithelial tissue. Then again keratinization of the urinary tract epithelium. Vitamin A, there will be growth retardation, there will be infertility, then there is preventable blindness due to dietary deficiency of vitamin A. So it is preventable this blindness. That's why to prevent the blindness, the government of India has started a national-wide program, National Blindness Control Program. Here, as a part of this, we give vitamin A solution during their immunization every 6 months, 1 lakh unit to prevent this infantile vitamin deficiency in the childhood. Growth retardation, skeletal muscle growth retardation, growth is retarded due to defective synthesis of chondroitin sulfate. Infertility, sterility in males, cornification of the vaginal epithelium in females, that occurs due to the vitamin deficiency because of the failed differentiation of the epithelium. Now, as it is vitamin, fat-soluble vitamin, it gets stored in the this adipose tissue and liver, and when it is given in an excess dose for a prolonged time, it causes hypervitaminosis A. Injection of excess vitamin A, about 30,000 microgram per day for months, causes hypervitaminosis A. Or inappropriate therapy. High dose of synthetic vitamin is given for prolonged period. Criteria: there should be more than 300 microgram per gram of liver tissue. The retinol activity should be more than 300 microgram per gram of liver tissue. Liver tissue is taken, a biopsy is taken, then from there retinal activity is measured. If it is more than 3000 microgram per gram of the tissue, then we consider it is hypervitaminosis A. Hypervitaminosis A. The plasma vitamin concentration will be more than 140 microgram per deciliter in hypervitaminosis A. Symptoms will be anorexia, headache, drowsiness, vomiting, then bony exostosis with painful swollen bones, means bones, a small portion of the bone will be swollen, okay, like a tumor. Small portion of the bone will be swollen, and this is called exostosis. Dry skin will be there, itching will be there, then hepatomegaly or liver cirrhosis in children. Because of the excessive collection of vitamin, there may be cirrhosis of liver. Then there will be alopecia, fingernail dystrophy. Deficiency assessment in vitamin A. So it is done by dark adaptation test. Dark adaptation test will be prolonged. Then retinal binding protein level will be decreased. Normal is 3 to 6 milligram per deciliter. Vitamin A level will be decreased. 25 to 80 microgram per deciliter is the normal value. Treatment is given 15 to 60 milligram of vitamin A. It is equivalent to 15,000 to 60,000 international units per day, orally for 1 to 6 months. Vitamin A we find sometimes used as therapeutic purpose. All-trans retinoic acid. It is used as a treatment for promyelocytic leukemia, psoriasis, the skin disease. They have to apply it on the skin. Then isotretinoin. It is nothing but the 13-cis retinoic acid. It is used as acne treatment cream. Then beta carotene we use as antioxidant. Traps peroxide free radical in tissue at low partial pressure of oxygen. Risk of cancer is removed, decreased risk of cancer. Then oral leukoplakia, precancerous condition, revert to fully differentiated normal epithelium, because it is a differentiation, it has a property for epithelial differentiation. No? So in the mouth, you will find those people who take more this pan, so they will have whitish discoloration and thickening of the mucus inside the mouth. Okay, so if vitamin A is given, that can be reverted completely. Now a case study. So everything we have discussed, you prepare it. Okay, case study. MCQ. Vitamin A form that combines with opsin to form rhodopsin. Which one is combined with opsin to form rhodopsin? It is 11-cis-retinol. Okay, so get this. So questions you can get from here. So we'll proceed with the next vitamin, vitamin E. So vitamin E, it is again a fat-soluble vitamin. Tocopherol, it is another name. Tocos related to childbirth, pherols to beer, all alcohol. So in animal, in rat, it has been found that deficiency of vitamin E causes infertility. So it is also called vitamin anti-infertility vitamin, and it is also called a vitamin it is also an antioxidant. Daily recommended allowance: adult 15 mg per day, children 11 mg per day. Then pregnancy 15 milligram per day and lactation 19 milligram per day. 15 milligram of vitamin E is equivalent to 33 international unit of vitamin E. Requirement increases with higher intake of PUFA, polyunsaturated fatty acid. Polyunsaturated fatty acid, as it is unsaturated, it has a tendency to get oxidized. So, if more amount of polyunsaturated fatty acid is taken, then along with that, more amount of vitamin E also has to be taken. Otherwise, this polyunsaturated fatty acid, it will get oxidized. Like that of the vitamin A, it is also micelle formation is required for its absorption. Then from the intestinal cell through chylomicron, it is transported via lipase to circulation, then to the liver. And from liver, it is transported with VLDL in the peripheral tissue. So in the peripheral tissue, VLDL is converted into LDL. So it is then transported via LDL. And it is released in the peripheral tissue as an antioxidant agent. And this is a membrane antioxidant. So it is having antioxidant property. It is responsible for cell membrane integrity as it is membrane antioxidant. It is bound to the membrane and prevents oxidation of the phospholipids, which is present in the lipid bilayer membrane. Okay, it prevents oxidation of the phospholipid. Phospholipid has a unsaturated fatty acid also, no? So that is prevented. The unsaturated bond is it should not be oxidized by the free radicals. So it prevents free radical damage of the membrane. Then most important in membrane RBC of the membrane. RBC of the membrane, here the hydrogen peroxide is generated in the RBC, which is also a free radical. So there it is preventing damage of the RBC membrane. Then anti-atherogenic effect. It is because of the LDL. LDL is prevented from getting oxidized. So if it is not oxidized, it is spared. That will not be responsible for production of the atherosclerosis. So once atherosclerosis is not produced, the heart attack or the ischemic heart disease is prevented. Then anti-inflammatory action is there. Role of fertility. It has a role in fertility and it has also a role in immunity. Here, how the lipid peroxidation is prevented by vitamin E is shown. Here, PUFA is there, phospholipid is there in the PUFA, polyunsaturated fatty acid. So, free radicals, they will oxidize the polyunsaturated fatty acid and produce polyunsaturated fatty acid free radical. That is also called a lipid peroxide radical. And this one, it goes on oxidizing the other free radical, unsaturated fatty acid. There is a chain of oxidation. So that is very dangerous. Now, this vitamin E, what it does, it accepts the free radical and gets converted into phenoxy radical. It itself gets converted into a free radical. So this chain is broken. This chain is broken. So polyunsaturated fatty acids are preserved. Now this phenoxy radical, it is a stable free radical. It doesn't continue to oxidize any other thing. But to keep the chain continuing, we have to recover this vitamin E, and that is done by vitamin C. That reduced vitamin C, it accepts this one free radical and get oxidized to vitamin C. Again, to continue this vitamin C cycle, we need to recover this vitamin C, reduced vitamin C. That is done by the glutathione peroxidase. The reduced glutathione peroxidase, it accepts the oxidant from the vitamin C and get itself oxidized into oxidized glutathione peroxidase. And glutathione, oxidized glutathione. This glutathione, oxidized glutathione is recovered by the glutathione peroxidase with the help of NADPH to reduce glutathione. So the cycle is kept on going. So vitamin E is a chain breaking antioxidant, and it is present in the cell membrane, so it is protector of the cell membrane. So here it protects the cell membrane, then lipoproteins, RBCs, mitochondrial membrane, and retina. These are the important structure which is protected. Sparing effect of vitamin E on selenium. Selenium is a content of, there are catalase, then superoxide dismutase. They also neutralizes these free radicals, hydrogen peroxide. So when these are there, the amount of vitamin E requires less. That's why this selenium has a sparing effect on vitamin E. Vitamin E deficiency, impaired absorption due to cystic fibrosis, short bowel syndrome, bile duct obstruction, beta lipoproteinemia. Then deficiency manifestations are hemolytic anemia, as due to its deficiency, the RBC membrane cannot get protected, and there is hemolysis. Retrolental fibroplasia, it is in the eye. Then peripheral neuropathy and myopathies, poor nerve conduction, spinocerebellar ataxia. These are all due to the free radical damage. A normal referral interval is 0.5 to 1 milligram per deciliter, normal level of the vitamin E. Vitamin E toxicity is very rare. It is the least toxic fat-soluble vitamin. So these are the important things about the vitamin E. So vitamin E you will get as short note, and vitamin A you may get as long answer type of question. Okay. So these vitamin E reduces the requirement of iron, zinc, selenium, magnesium. So it is selenium. Then structure of vitamin E contains bromine ring, beta-anon ring, then thiazole ring. The ring present in vitamin E is known as bromine ring. The vitamin that is termed as cell scavenger is vitamin E. The vitamin which is more effective at high oxygen concentration is beta-carotene, tocopherol, ascorbate, and calcitriol. This is tocopherol. Dietary requirement of vitamin E is elevated with the increased consumption of PUFA, saturated fatty acid, cholesterol, protein. It is PUFA. If you increase the intake of polyunsaturated fatty acid, then you increase the vitamin E consumption also. Okay. Then all of the following statements about vitamin E are correct, except beta-carotene complements the antioxidant property of vitamin E. Yes, because both are antioxidant. Vitamin E is a chain breaking oxidant. Yes, it is chain breaking. Vitamin E and selenium act synergistically to reduce the risk of lipid peroxidation. Yes, both of them they act synergistically. Vitamin E is highly effective at low oxygen concentration. No, this is highly effective in high oxygen concentration. So vitamin E is responsible for all the following except prevents lipid peroxidation in biological membrane. Yes, prevents RBC from hemolysis. Yes, it is considered to be the anti-sterility vitamin. Yes, it favors the oxidation of low density lipoprotein. No, it prevents the oxidation of low density lipoprotein. So we will finish here. Next class we will discuss vitamin D and vitamin K.